دخلوني.
هاي
السلام عليكم ورحمة الله.
عليكم السلام ورحمة الله.
السلام ورحمة الله وبركاته.
وعليكم السلام ورحمة الله.
الصوت واضح شباب؟
اي واضح.
ممكن الهوست بالله يسمح لنا بالشير؟ إلى الآن الشير مسكر.
On the third one.
في أيضا تعليق إنه في ناس بالويتنج روم، إذا في مجال الهوست يدخلهم. إلى الآن الشير مو ظابط.
Recording in progress.
معذرة منكم، جالسين نتواصل مع الهوست. أتوقع المشكلة انحلت هلا. معلش، الهوست انعطى الحساب الثاني اللي أنا داخل منه، كنت انعطى حساب الثاني. أيوة الهوست انعطى أنا داخل بجهازين، فبدي الهوست الحساب الثاني اللي هو الكمبيوتر. عدلت اسمه، صار اسمه كمبيوتر، يا ريت إذا طيب التعديل صار من عندي أظن. طيب
In progress.
صار إنه المشكلة انحلت هلا أعتقد. تمام. معذرة منكم. السلام عليكم ورحمة الله وبركاته. الصوت واضح إن شاء الله؟
واضح.
تأخر اللي صار. بسم الله الرحمن الرحيم. في حدا is there an Arabic student listening?
Yes.
There are
Non-Arabic.
Okay, you are welcome. Tonight, inshallah, we are going to talk about basics of ECG and the systemic approach of interpreting ECG. Actually, interpreting ECG is an essential skill for any general practitioner. You are required to analyze ECG if you are a general practitioner or you are working in the internal medicine field. ECG machine is there in any primary care setting. So, knowing how to interpret an ECG is an essential skill. And this session is an essential for understanding all the ECG topics. So, inshallah, by the end of this session, you will be able to go smoothly through this course and understand the topics. I'm محمد إبراهيم طريفي طالب سنة خامسة. طيب what to discuss in this presentation, two things. First one, the basics of ECG, how this paper and how these lines are formed and what do they present. That is the first thing in our presentation. And the second thing is a systemic approach for interpreting an ECG paper. Okay, so first thing, when your heart is complaining, it could complain emotionally, and it could complain also organically. So in this session, we will let the emotions beside, and we will focus only on the organic diseases or organic complaints of the heart. When you have emotional complaint, you can cry, and some might talk to others, and some are strong. They don't say it to anyone, and they hide that. But when your heart is complaining, how we can know that there is a problem in the heart? We can know that from chest X-ray. It can tell us many of the heart. To take more information, we can do an ECG, which is the corner of this course. And also we can do an echo and other investigations that could tell us about the heart condition. Now I want your participation. Could you tell me something easier than this investigation that could tell us about the heart health?
Heart rate.
Heart rate, you are great, because we are treating patients. We are not treating an ECG. So always don't forget the clinical part of your work. Assess the vital signs, assess the blood pressure, do the cardiac examination. It could tell you many about the patient condition before utilizing this investigation, as it sometimes costs. Okay, so don't forget the clinical part. Okay, so we know that we have this pads and this cable attached to the body of the patient. I think you have seen a patient before in this condition, and we have this ECG paper. Our job in this presentation is to know how this electricity or how these cables give us this paper, inshallah. So these cables are called electrodes, and these lines represent the leads. How many electrodes do we have placed on the body of the patient?
10.
10, you are right. And how many electrodes are there in the ECG paper?
4.
Are you sure?
9.
Let us count them. We have here 1, 2, 3, 4, 5, 6, 7, 8, 9, 12, 9, 10, 11, 12. We have 12 leads on the ECG paper. You have to know that we have 12 leads on the ECG paper. This lead 2 is redrawn again here with extended time. And here it's only, let us say, 15 big squares. Here it's more. So we have 12 leads. These cables are connected to the ECG machine, and it will print the paper. And this paper should be transferred to your mind to bring the diagnosis and to know the disease and to know the condition of the heart. Okay. So now we will just review the basic physiology of the heart to understand the basics of ECG. As you know, the heart is having its internal conductive system of electricity. The heart has its automaticity. Can anyone tell us what is the meaning of automaticity? What's the meaning of automaticity? First year students.
The ability to stimulate itself.
Yes, you are accurate. The heart could stimulate itself by itself. So you know that the heart is innervated by which nerve? Anyone know? The heart is innervated by the vagus nerve. So if we denervate the heart will still pump. The heart will still pumping. Whereas if we denervate, for example, the biceps or the triceps, they will atrophy because the innervation will not go to them. Whereas the heart has its automaticity. So it's firing independently of the nervous system. So we have here the SA node, and we have here the AV node. We have the AV bundle or bundle of His. Then we have the right bundle branch, and we have the left bundle branch, innervating the ventricle. Okay, let us remove the myocardium and keep these electrical wires inside the heart.
Trafy. Okay.
Yes. You have comment? I think someone left the mic open. Can you close it, please? Okay, so we have here the SA node, and we have here the AV node, and we have here the internodal. Yes, we have here the internodal pathways, and we have the bundle of His, and we have the bundle branches, the right one and the left one. Here, bundle of His. Anyone know what is related to the physiology of bundle of His?
Transit oneness. ولا اثنين.
Please, I think someone left the mic open.
ايش بعد اماكن في الرياض؟ رحت اتعشى في الانتركوت بس اتوقع يبغى له حج.
We have sorry. So that. طيب, anyone know the function of bundle of His? First year student, I'm expecting you to participate here because it's يعني هي لعبتكم يعني physiology الآن. Okay, bundle of His delay the transfer of electricity from the atria to the ventricles to allow the atria to contract before the ventricles. Okay, so let us focus here on this sinoatrial node and draw its physiology. Why it has atomicity? Because the resting membrane potential of the SA node is not stable like the myocardium. It always goes from repolarization toward depolarization. So it's always depolarizing. So for that we have the automaticity. Whereas the myocardium, it needs an electricity that coming from the SA node to depolarize and then to contract. So this is why the heart has its automaticity on a cellular level. Okay, everything is understood up to this level. I hope. Here there is a presentation of the time needed from the impulse to reach different parts of the heart. As you know, here from the SA node it reaches the end of the left atrium by 0.09 seconds, and then it reached the ventricles by 0.22 seconds. Why there is delay between the atria and the ventricle? Due to the AV bundle branch, to the AV bundle block. Okay, so when the myocardium here, the myocardium is depolarized from the conductive system, the electricity will transfer from one cell to another. Could someone tell us what is this structure represent? What does this structure represent?
Gap junction.
Yes, gap junction, great. The electricity will be transferred from one cell to another by gap junction. So all the myocytes will contract together. Yeah. Okay. So we know now.
The number is important here.
What? Can you
In the
repeat the
previous
question?
slide. In the previous slide.
Yes.
The number is important.
No, not important. Just for illustration. Don't memorize them. That's for illustration that we have delay between the atria and the ventricles.
Okay.
Come on. Everything is understood up to now? I hope. Okay. So as we know, this is a sample of the muscle. We take, for example, sample from here and we draw it here. So this is an example of the muscle. So as you can see here, that the electricity is flowing from this side to this side. So if we represent that, for example, this is the muscles here. This is the muscle, okay? So the positive charge is going from this side. It's similar to here. Positive charge going from this side to this side. So if you place a voltmeter, يعني الجهاز اللي يقيس الفولت, and we connected its negative end to this side and positive end to this side, this voltmeter will record positive volts, because when the positive charge goes toward the positive pole of the voltmeter, it will record a positive charge. Is this point clear? This point is the basic of ECG. This image is the ECG. If you understand this, you will understand the whole ECG. Is it clear? I hope. So here, when we see that positive charge is going from the negative electrode toward the positive electrode of the voltmeter, it will record a positive wave. So when all of these myocyte is depolarized, so it will record an upward wave. Okay, whereas when there is repolarization, the muscle is going from negative to positive. Yani the muscle now in depolarized state. There is no movement of the electrons or ions here. So when start repolarizing, the negative wave in negative ions inside the myocyte is going toward the positive pole or positive electrode of the voltmeter. So when negative charge goes toward positive electrode, it will record a negative wave. Is that clear? It will record a negative wave. I hope that is clear.
Yes.
Now, after applying this concept is like an electricity concept, not related to the cardiology, but engineers and cardiologists work together and they made the ECG from this concept. As you know, and as we explained first, that the heart has the electrical conductive system inside it. So it goes from the atria toward the ventricle. So if we place an electrode here with positive charge and the negative charge on that side, what the electrode will see? I want you to imagine the electrode as an eye. يعني الالكترود عبارة عن عين انت جالس تنظر منها للهارت. فإذا كان في عنا عين أو الكترود أو an eye looking for the heart from this side, how the wave will be? Can someone tell me?
Can you repeat the question?
I am saying in this electrode, I hope this electrode is clear for you. We have here a negative wire like this, and we have a positive wire like this. So our eye will be from the positive side. Yani we are looking from the positive side. What the voltmeter will record as the impulse is going from up to down. Positive is going to positive. What it will record?
Left leg.
It will record a positive wave. As you asked.
Oh.
Yes. Anyone have comment?
No, Dr. Ryan, I just say the positive reflection because the electrons during depolarization, they will move from the SNO side towards the apex of the heart, so towards the positive, so they will record positive deflection.
Yes, you are right. So it will record a positive deflection. Okay, I hope this is clear for you. Anyone has a misconception or didn't understand? Please tell me. Okay, now we can proceed. Yes. Okay, now we can proceed. They took the same idea and they invented the ECG. What they did, they take the same idea. They put a positive electrode here and on the right hand, and a negative electrode, on the left hand, and negative electrode on the left hand. So we are having here what? We are having like an eye looking to the heart from this side. Why? Because we have here a negative electrode and we have here a positive electrode. So our eye will be always from the positive side. So by doing that, they put a negative electrode here and a positive electrode here. We are looking to the heart from this side. This is called lead 1. And they apply the same idea for lead 2. We have a positive electrode connected to the left leg, okay, and a negative electrode connected to the right arm. So we will have an eye looking to the heart from this side. We are looking to the heart from the inferior surface of the heart because the positive electrode is here. Our eye is from the positive, okay? And they did the same for the third lead, and we get an eye from this side. So this is lead 1 and lead 2 and lead 3. I hope this is clear for you. Any question? I hope that's clear. Okay, so we have also 6 chest leads. Those are called limb leads. Okay, we have 4 places to connect. We have 4 electrodes to connect on the limbs, and we have 6 electrodes to connect on the chest. So totally we will have 10 electrodes, as we said in the beginning of the session. So we'll have here 6 on the chest and 4 on the lead, 4 on the limbs. So this 4 on the limb will give us 6 leads, and this on the chest will give us another 6 leads. We just said here we have 3 leads on the chest lead, but we have on the limb lead, sorry, we have here we mentioned 3, but also there is another 3, as we will see now in a moment. Here I put a reference for you to know where to put the electrode. Yani, where is the place of the V1 electrode, V6? You can read it by yourself. It's like a clinical skill matter, not an ECG directed. Okay. Okay, as I said, we have 6 chest lead here. They are looking to the heart from this side. It's a horizontal. This is the body of the patient or normal person, and we are looking. V1 is looking like this from this side to this side. We have an eye looking to the heart from this side. We have an eye looking to the heart from this side. And V3, V4, V5, V6. These are the 6 leads. 6 chest leads, and we have here the 6 limb leads. We have lead 1, as we mentioned earlier. We have lead 2, we have lead 3, we have AVL, we have AVR, we have also here AVF, sorry, here where is AVF? Here AVF, we have here AVF, and we have here AVL. Don't get bothered by the name, just memorize them and know which angle does each lead correspond. Okay, so lead 2 correspond to the 60 angle, lead AVF, for example, correspond to the 90 angle, lead 3 120. And also remember where is the positive side of each lead. Lead 2, as we mentioned earlier, have the positive side here, and lead AVF positive side here, and lead 3 positive side here. Imagine that the heart is in this place. So we are looking from inferior to the heart. We are looking from inferior to the heart. Here, superior, and here, inferior. Here is the left side of the patient, and here is the right side of the patient. We have here looking from inferior. We have this inferior lead, lead 2, AVF, and 3. We have here the lateral leads, which is 1, and AVL, looking from the lateral side of the heart. And also we have the other leads here. Like how these 12 leads are going to show the heart. يعني هون عندنا نحن الهارت، تمام؟ فكل ليد بخلينا نشوف الهارت من زاوية معينة. يعني كل lead represent a camera looking and recording the electrical activity in the heart. What is the importance of that? What is the importance of that? Can anyone tell us of having different leads?
So in the case of ischemia, we can easily get the part of the heart that is infected or not.
Yes, accurate. We can localize the part of the heart that is ischemic. Okay, and after localizing the part of the heart or the anatomical location, we can know which vessel is occluded. As you know that the heart supply, the coronary artery, we have left coronary artery and right coronary artery. Left coronary artery give the left anterior descending and give the left circumflex artery, and right coronary give the right marginal artery. So knowing these leads and it's correlated anatomical part is essential for diagnosing STEMIs, ST elevation, myocardial infarction, or ST depression, for example, non-STEMI. Okay, clear till now?
Can you repeat the picture on the right side?
Which one, this or this?
This
Below.
at the below, yes.
Yes, okay. To make it simpler, look, let us go back to here. As I said, that we have here lead looking, we put here a negative wire and we put here a positive wire. So we have an eye looking to the heart from this side. Okay, this lead 1, clear?
Yes.
And here also we have negative electrode and positive electrode here. So we are looking to the electrical activity from this side. This is lead 2.
Clear?
Okay.
And
Yes.
also this is lead 3. Looking from this side, from negative to positive. So this is lead 3.
Okay.
Tamam. So you are now down with 3 leads. This lead 1, as I mentioned, here lead 1, going from negative to positive. So the eye is here. And this is lead 2, going from negative to positive. So we are looking from here. And we have here lead 3 from negative to positive. Is it clear?
Yes, clear.
Okay.
But what
Oh,
about the number?
yes. Which numbers?
This number 0, 30.
Yes, this is a circle, right?
Yes.
صح? So lead 1 is on the 0 degree of this circle and measuring the يعني بالفرجار measuring or بالمنقلة يعني measuring the angle, it's 60. From here to here it's 60, right?
Yeah.
And from here to here, from 0 to this line, it's 90. And from here it's 120. 120, yes.
Okay.
Okay, clear?
Yes.
Okay, up to here it's 270. Okay,
Yes.
but here they don't complete until 360. This quadrant is يعني calculated بالminus. يعني from here to here is minus 30, from here to here minus 60, and from here to here is minus 90. Clear?
Yes, clear. Thank you.
Tamam. This is the idea of the degrees. We will utilize these degrees in the cardiac axis, as we will see in the next slides.
Okay.
Tamam. And also we just mentioned now 3 leads, 3 limb leads. These are the chest lead because they are placed in the chest, and these are the limb leads. Okay, we have another 3 limb leads. We have AVL, we have AVF, we have AVR. What's the idea? The same concept here, the same concept, but they put a resistance يعني مقاومة، فبيطلع عنا بسموهم augmented limb leads، فبيعطونا زوايا مختلفة. They give us another angles to see the heart. So totally we will have 6 limb leads. Each lead will show us the heart from a different angle, and that is important to يعني localize the lesions and to know what happened in each part exactly. Is it clear from where we get these leads?
Yes.
Okay. طيب. Now, as you can see, we have this horizontal
Ibrahim,
plane. Yes, تفضل.
before you move, there is one student that's asking why the degrees are moving in this direction.
Let me open the chart. Why the degree of the circle is going that way? I didn't understand. What way you mean?
So he mean, I think from 0 degree, we go like anti-clockwise direction.
Yes, anti-clockwise.
So
Here you mean.
I think that's why he is asking.
يعني they like used to يعني count this quadrant by this way, because you will find, for example, in the textbook they are saying from 90 degree up to minus 30, it is normal heart axis. And they are saying that from here to here, normal heart axis. Maybe to simplify thing and not saying, for example, 280 big numbers, it's easier to deal with small numbers. I guess, yeah, not sure why they do that. I hope that's clear. Okay. Now, in combination of the 12 leads, we can get like a 3D image for the heart to know what each part exactly what is having. As you can see here, that sometimes they put V8 and V9, and sometimes they put right-sided leads, but that's not always. Yani in some conditions they do that, but for the simple ECG reading, we are just concerned with these 12 leads that they are usually done. Okay, clear? As I said, this is, imagine always the electrode as an eye looking to the heart, and it's always from the positive place. So here the AVR is looking from this side to the heart. Okay, so everything happening in the other lead will be opposite in AVR. Okay, because it has its positive end from this side. Okay. This is a table. I think it's a well-known table and famous one. everyone should know by the heart and know which lead and the corresponding anatomical area and also the blood supply to this area. For example, V1 and V2, they are looking to the anterior septal part of the heart and they are supplying by the left anterior descending. So when you see, for example, ST elevation in V1 and V2, you know that it is anterior septal and the artery occluded is left anterior descending. And when you see 2, 3 AVF lesion, you have to know that this is an inferior, for example, MI, and the occluded is right coronary artery. This should be known by heart. Go and revise it by yourself until you memorize it by heart. Okay, and also it's presented in the ECG paper. 1 and AVL and V5 and V6 are looking for the lateral side of the heart. 2, 3, sorry, I said AVL here. 2, 3 AVL are looking for inferior side of the heart. Okay, and V1 and V2 are looking to the anterior part of the heart. I hope that's clear. We can return back here to see that V1 and V2 are looking for what? For the anterior septal. V3 and V4 are looking for the anterior apical. V5 and V6, they are in the lateral side of the heart. This is the lateral side. So are considered lateral lead. And also 1 and AVL are considered what? Lateral leads. So this will look V5, V6, 1 and AVL look from the same side. Okay. And 2 AVF3, they are looking from the inferior to the heart, So now I think all of you know what does every lead on the ECG paper represent. I hope now it's clear for you. Is it clear? Okay, I hope.
Yes, clear.
Okay. As I said in the beginning that we have this electrode, we are like, yes? Fine. We have now this electrode. Can anyone tell me what this electrode is?
B wave, what is it?
What is this electrode?
Lead 2.
Lead 2.
Yes, this is lead 2. Yes, you are right. Lead 2. So we have here the atrial depolarization. It's represented by the B wave. And we have here the QRS complex represent the ventricular depolarization. And then we have the T wave, what represent the ventricular repolarization. Okay, clear?
Yes.
This is another image to make things more clear. As you can see here, 1 is what? Is the atrial depolarization. And 2, it's what does 2 represent?
It's complete, so atrial depolarization.
Yes, the complete of the atrial depolarization. And why it's held, يعني why we don't see the B wave على طول يعني جنب ال QRS؟ ليش في الفراغ هذا؟
ال AV node.
ال AV bundle، ما هي ال AV node، AV bundle. Okay, the AV bundle will delay the electricity or the electrical current delivery from the atria toward the ventricle here because it has high resistance, so it will delay it. So we will have here this BR segment. Okay, then we have the QRS complex represent the ventricular depolarization. Okay, we can see the ventricular depolarization. Then we have ventricular repolarization. Okay, it's represented by the T wave. I hope this is clear.
Yes, clear.
Okay. I have a question. We said that when we said in the beginning, I think very early thing mentioned. Yes, we said here when we have a repolarization, okay, the negative waves are going toward the positive electrode, the voltmeter will record a negative wave, right? We agreed on that in the beginning, صح? صح.
Yes.
I just want to add to your information one thing. When we have negative waves are going away from the positive electrode, the voltmeter will record a positive wave. Let us repeat. For example, here the negative wave is going from this side to this side, okay? If we reverse it, we make the negative side is from here, and let us explain here. For example, if this positive side could start, let's put pin, it start going negative from this direction, negative, and we have here what? The positive electrode, and we have here what? The negative electrode. So when the negative wave are going away from the positive electrode, the voltmeter will record a positive wave also. So it will record positive waves in two conditions. First one, when positive ions are moving toward the positive electrode, there will be positive wave. And when negative electrons are going away from the positive, it will record a positive wave again. I hope this is clear.
Yes, it's clear.
Clear. Okay, great. So now we can proceed. Okay, now as you can see, I would ask you, why T wave is positive?
أول شيء بسكر أنا طلع فرن أوفر الفانكشن كلوز فرن أوفر أول فرن
Yes.
بعدين 1 2
Yes.
من 1 3 أول بعدين
Sorry, can you close your mic?
1 2 أول.
طيب. Anyone can tell me why T wave is positive?
As we just said now, it is the repolarization of the ventricles. So the negative waves are going to the away from the positive, going to the negative side.
Great,
So
Ali, great. Yes, that's exactly. Yes, as you can see here, that if we place the same electrode, and here we have the ventricular repolarization. Repolarization means the positive myocyte is going down to have negative charge. So the negative will go from this direction, as you can see here. The negative or repolarization is going away from the electrode, away. It's going away. So the ECG machine will record a positive wave. That's why we have a positive T wave. That's why we have a positive T wave, even that we have a repolarization. I hope that point is clear for you. I hope. Thank you.
Yes.
And now let us take the ECG component. You have to know also this by your heart. You have to know this component by your heart. I want someone clever to tell me the difference between the interval and a segment. Could someone tell me what's the difference between an interval and a segment?
Yes.
Yes.
Segment represent the distance between the atrial depolarization and the ventricle depolarization. Or you mean as general, or what?
As in general, not only one condition.
So it represents the distance between the depolarization and depolarization and depolarization.
Actually, yani, what you said is yani, somehow correct, but we want a certain definition. The segment represents a period in the ECG paper without a wave. Yani, if you look here, we have a period in the ECG paper, but there is no wave. So it's called what? BR segment. But when we include the B wave inside, now it's called BR interval. Okay, is the difference clear between interval and segment?
Sorry, can you repeat about interval?
Okay, we said that the segment is a period or يعني خط على a line on the ECG that doesn't contain a wave. ما فيه wave.
Without wave, yes.
Without wave. Whereas the interval is a period on the ECG that contain wave.
Okay.
Okay, look here we have BR interval, but when we remove the B wave, it's called only BR segment. Okay, clear. I want someone also to tell me what is the most famous or most important segment in the ECG paper.
ST segment.
Great. ST segment is the most important segment, and only we have two segments, by the way. Yeah. Yes, because why?
Because it can diagnose abnormality or
What abnormality?
elevation or depression in
Great.
myocardial
Infarction.
yes, infarction.
Yes, great. You are great. This is life-saving. If you take an ECG paper for a patient, and for example, imagine you are working in a village or countryside, and you have only a small polyclinic يعني مستوصف صغير وانت جالس تشتغل فيه, and you have an ECG machine and a patient came to you with chest pain. You did for him an ECG and you miss the ST segment elevation. Okay, imagine what might happen to this patient. He might die because someone missed the ST elevation, which is very simple and very basic. Okay, so interpreting an ECG is life-saving in sometimes. Okay, so we have here the BR interval. I think it's now clear. We have the BR segment. I hope it's clear. We have the QRS complex. Ignore this ST interval and TB interval. Ignore them. And we have here the RR interval. RR interval represent the distance between two RR wave, two successive or two يعني متتاليين يعني RR wave. تمام. And we have here very important interval called what? QT interval. Could someone tell me from where does the QT interval start and where does it end?
Do you mean the interval period?
Start from where?
It starts from the beginning of the depolarization of the ventricles.
Yes,
the end of the repolarization of the ventricles.
Yes, you have to, yes, great, Ali. You have to know for each segment and each interval where does it start and where does it end. Here from the image it's clear, but sometimes in the exam you forget, is it from the beginning or is it from the end? So BR interval from the beginning of B wave till the end of the Q wave, to the beginning of the Q wave. Q wave is not included. And why they call it BR interval? Why they don't call it BQ interval? Anyone know?
Maybe sometimes the Q wave is not present. So
Yes, great, Ali. Because Q is not always present, so they call it BR interval. R is the wave after Q. So BR interval from the beginning of the B wave till the beginning of Q wave. Okay, whereas QT interval, look at the difference. QT interval from the beginning of the Q wave till the end of T wave. Here, it's from the beginning of Q till the beginning from the beginning to B till the beginning of Q. Okay, here from the beginning of Q till the end of T, not beginning of T. So know by heart what does each interval represent. Okay. And the QRS from the Q till the S. And sometimes, as Ali mentioned, that Q is not present, so from R to S. Okay. Here we have what's called the J point. J point, it should be always isoalcatric. Okay. What does mean isoalcatric mean?
straight line.
Yes, no straight line. There is no deflection upward or downward. Okay. طيب. Here, I think we reached the end of our first section of this presentation. So one last thing to say before we end the first session, that we mentioned that QRS complex is composed of Q, R, and S. What does each one of these represent? A Q wave, it's the first negative deflection in the QRS complex. Okay, first negative deflection is the QRS, and R wave is any positive deflection. Okay, S wave is a negative deflection after R wave. Let us see an example. Or okay, here we have only look at this QRS complex. We have only a negative wave. We don't have an R wave. So this called QS wave. As we mentioned that the first negative deflection is Q. And you might think that this wave should be Q only, but they say QS. They call this wave QS. Okay. It's not one wave, but they call it QS. Look at here. We mentioned that Q wave is the first negative. You can see here we have Q wave is the first negative and R wave is any positive. Okay, someone is asking for the recording. Inshallah, recording it will be safe and we might share it, inshallah. No problem. طيب. For the Q wave also here, we can see it's the first negative and this is the R wave is the any positive deflection. As you can see here also, Q wave is the first negative and R wave is the positive deflection. Why this R wave is capital and why this R wave is small? Anyone know? Anyone could know?
No.
The size of deflection?
Yes, great, Mahmoud. When we have a small wave, they put a small letter. It's logical. And when they have big wave, they put what? A capital letter, R wave. Okay, for any wave here. If it's small wave in the amplitude, they put a small letter. And when it's high amplitude, they put uppercase letter. Okay, so look at this example. We have here QRS. This is the typical QRS. First negative wave is called Q, and any R wave and any positive wave is called R. And the negative wave after Q is called S. Tamam? Like as you can see here. Sorry, S wave any negative deflection after R wave, not Q wave. S wave any negative deflection after R wave. As you can see here, we don't have Q. So do we say this is Q? No. This complex is called RS because there is no Q. As we said in the before, and sometimes there is no Q. Here only R, and the negative wave after R is called S. Okay. When we have two R, when we have two positive deflection, what we say, they put dash for the second one. So R, S, R dash, and this is larger than this positive. So this is uppercase and this is lowercase. Okay, and for first negative deflection after R is called S, not the Q. After R is called S. Tamam? I hope this nomenclature is clear for you. Anyone have a question?
Dr. Ryan, could you just please could you recap again, please? Sorry.
Okay. Could you tell me, Ali, what is Q wave represent? Or what's the definition?
And the function of Q, and what is Q wave and depolarization of the interventricular septum?
Yes, great, great, Ali. I didn't mean that. I meant by the definition of the nomenclature.
No, that's even what I'm asking, honestly. Can you
okay.
redo it again? Yeah, please.
Okay. The Q wave is the first negative wave. Okay. Q wave is the first negative deflection. R wave is any positive deflection, regardless if it's the first, second, third, regardless, it is the R wave. Any positive deflection is called R wave. And S wave, any negative deflection after the R wave. So sometimes we don't have Q wave, so only we'll have R and S, positive and negative. Negative after the R is called S. Okay, for example, look at here. Here we don't have Q. We start directly with R. So after R wave, there is S wave. and here the first negative is Q. So Q R S. Okay. Clear, Ali?
Yeah, right. So just come this way again. The one that's next, for example, we have a capital R and a small r, which has prime. Yeah, that one. No,
Yes,
the lower one. Yes, this one. Yeah, exactly.
Yes, we said that R wave is any positive deflection. So we have here two positive deflections. So the first one is R, and the second one is R dash, regardless of the capital letter or small letter. Okay, when we see the amplitude, this amplitude is small, so they give it an R small, and this amplitude is high, so they give it capital R. If, for example, it was the reverse, it was the high amplitude here, it will be the R capital here, and if the low amplitude is here, it will be R small dash.
Yeah, right. So does it have a meaning now, this one, other than the?
Do you mean clinical or interpretation?
Yes. If you can just give an example, so that I can understand well.
Yes, of course. For example, in left bundle branch block, as it will be explained later in the course, we don't have an R wave in V1.
Right.
This R wave is absent in V1.
Right, yeah.
So you have to know this nomenclature, because you will find in the textbook that in this condition, there is pathological Q wave, for example. In this condition, the QRS complex appear in this shape, and appear in Q small, R capital, and S capital. They write like this. So you have to put this in your mind, because you will see the description, especially in the right ventricular hypertrophy, left ventricular hypertrophy, right bundle branch block, left bundle branch block. They use this nomenclature to put the rules for diagnosing these conditions.
Thank you, Dr. Ibrahim. Thank you.
Welcome. I hope that's clear. Right. As Ali mentioned, that Q wave represent the interventricular septum depolarization, and R wave represent the depolarization of the left myocardium, and the S wave represent the depolarization of the upper lateral ventricle. Yani here, okay, below this line, we have the interventricular septum. It will depolarize first, so it will have Q wave, and the remainder of the myocardium will then depolarize, so we'll have R wave. And this part of the heart, which is posterior and lateral upward, the last two depolarize, so it is the S. Okay, clear?
Yes.
Okay, just one.
I have a question.
Okay, one minute, please. Just. I want to remove this electrode. Let you see better here. Okay. As I mentioned, that first we have the interventricular septum depolarization. Okay, interventricular septum depolarization, it's a Q wave. And why Q wave is negative? Because the interventricular septum depolarizes from the left side to the right side. Let's make a pointer. Here, it depolarizes from this side to this side, like this, from here to here, like this. So this will appear in the ECG as a negative wave, because it's the electricity, the positive is going away from the eye. It's from here to here. It's a negative, yani. Okay, from here to here. This is how the interventricular septum depolarizes from the left to the right. So it will appear for this eye as it's going away from it. So it will record a negative wave. Whereas in the myocardium, when it depolarizes, it appears like this toward it. So there will be a recording of R wave. Okay, and S wave, these waves will go like this toward the upper lateral part of the heart of the myocardium, left myocardium. So it will appear as going away from the lead. So it will be recorded as negative wave. I hope that's clear. Okay, your question?
Yes. About the J points.
Yes.
يعني هي بتكون عند segment ولا كمان الانترفال؟
Again.
الJ point
Yes.
هي بتكون عند السيجمنت والانترفال ولا بس عند السيجمنت؟
ما يعني أي segment تقصدي؟ تقصدي البي ار انترفال؟
أو بشكل عام يعني هي بس بتكون موجودة عند السيجمنت ولا كمان عند الانترفال؟
لا الجي بوينت هذا مكانها فقط بالاي سي جي. تمام، مكانها عند نهاية الاس وبداية الاس تي سيجمنت. بداية الاس تي سيجمنت.
أيوة
تمام.
يعني ما لها مكان تاني. أيوة.
لا بس مكانها عند بداية الاس تي سيجمنت، زيها زي البي، زيها زي التي، كل واحدة لها مكان.
يس.
واضح؟
أيوة واضح.
تمام. طيب. Now we have finished our first section of the presentation. I hope you are يعني everything was clear. طيب actually I'm interested in knowing how many people are يعني following this course. So please can you raise your hand so we can know who is يعني following for us. There is no will be no mark or something like that, but we are يعني interested in the quality of the course. Okay, great. ما شاء الله. طيب. Now we will proceed for the systemic approach of reading the ECG. طيب. First thing, we have a step called calibration. What does that mean? You know that we have this ECG paper. Okay, it's composed of squares. All the ECG paper is composed of square. We have here a small square and we have a larger square. This one is the big square here, large one. From here to here, this is the large square. Each large square contains 5 small squares in the width and in the height. Okay, this is how the ECG paper is formed. It's composed of squares. Each 5 small squares represent one big square. تمام. Now these values you have to know by heart also. You have to know these values by heart. The x-axis or the duration of the small square, this one is small square. The duration is 0.04 second, or let's say 40 millisecond. يعني 40 ملي سكند. بدل ما نقول 0.04 سكند ممكن نقول 40 milli second. And when we have 5 small squares, تمام, we will have 0.2 second or 200 millisecond. Okay, I hope that's clear. يعني multiply 0.04 by 5, you will have 0.200 second. Okay, or 200 millisecond. This is about the duration of the small square and the big square. This small square amplitude is 1 millimeter. Okay, 1 millimeter in length, and it represents 0.1 millivolt. Okay, so having 5 small squares, you will have a half millivolt and 5 millimeter. I hope that's clear. Is it clear? As we mentioned, we can see here, small square duration is 0.04 second or 40 millisecond. Multiply by 1000, it will be 40. And the amplitude is 1 millimeter or 0.1 millivolt. Okay, as you can see here. And the large square duration is 0.2 second or 200 millisecond. And the amplitude for it is 5 millimeter or half millivolt. Okay, this is the amplitude. So, okay, so 5 small squares equal 1 large square. Okay, 5 small equal 1 large. Okay, so can 5 large squares equal how much time? Five large squares equal 1 second, because
One second.
yes, if you multiply 0.2 by 5, you will get 1. You will get 1 second. So if I want, for example, 6 seconds, how many large squares I have to count?
300.
No. If I want 6 seconds, how many large squares I have to count?
25. 25.
25, yes.
This is part how it's come in the exam.
Now?
This
Sorry,
is part-
sorry, we said 25, not 25, 30, because we will multiply this by 6. Okay, 6 large squares will be 30 large square, not 25. I'm sorry. Okay, you were asking how this will come in exam.
Yes.
This actually will not come in exam. Do you know why? Because it's very simple. It's like asking you about the ABC, so it will not come in exam. So just put it in your mind, and as you will go further, you will know how we will use this. Okay.
Okay.
Okay. In the next slide, you will understand what's the importance of knowing this duration and this amplitude, because you need to know. And for example, if you have here, for example, if you have a wave like this, is it similar to wave which is like this? No, there is difference. This wave has a higher amplitude. Okay, so you have to know that going up is having more amplitude, and going in the horizontal, it's going to have more duration. You have to know that. Okay, and also you have to know to make sure that the machine which we just see in the beginning is having a speed of 25 millimeter per second. This is like an option, and in the machine, make sure that it's 25 millimeter per second. Okay, is the calibration clear?
Yes.
Okay, so next, after the calibration is done, we will look forward for the rhythm of the heart. What does rhythm mean? Rhythm mean يعني النمط اللي ال QRS complexes are going after each other. هل هو regular أو irregular؟ تمام؟ طيب ايش الرhythm الطبيعي؟ What's the normal rhythm? It's the sinus rhythm. How we know this is a sinus rhythm or not? We have first to assess the rhythm in 10-second strip, which they put at the lower end of the ECG paper. They usually take the lead 2 and elongate it at the end of the paper to give you an enlarged or prolonged view of the lead. Okay, so you look to this lead, not to this lead which are short to assess the rhythm. Look at this lead. Okay, then how to determine that this is a sinus rhythm? What's meaning that the firing of the heart is from the SA node, and all the heart is governed and controlled by the SA node. B wave should be positive in lead 1, 2, and AVF. If you look here, lead 1, B wave is positive, and B2 is positive, lead 2 is positive, and also AVF, it's positive, or AVL is positive. Okay, it's present and positive because sometimes it might be absent. So you have to make sure that B wave is present to say this is a sinus rhythm. Okay, positive in lead 1 and lead 2. Okay, next thing, it's negative in lead AVR. Where is AVR? Here. As you can see that it's negative in lead AVR. Because as we mentioned that lead AVR is looking for to the heart from the opposite side, which record negative waves. So it should be negative. Tamam? And the third thing, every B wave should be followed by QRS complex. Yani look here at this strip. We mentioned that we will analyze it at the long strip. B wave, QRS, B wave, QRS, B wave, QRS. Every QRS is preceded by B wave, okay? And B wave is present always. then we look for the BR interval. BR interval should be regular. طيب, we just mentioned that the BR interval is from the beginning of the B wave, okay, till the beginning of the R wave. So here, from the beginning of B wave till the beginning of R wave, it is the same. Here, it's the same of here, the same of here. They are like a copy. So BR interval is regular. Tamam. Then the QRS complex, it should be preceded by B wave, which they have the same meaning of followed by QRS complex. Okay. Now we can say that this rhythm is regular. Tamam, if it's fulfilled this criteria. Rhythm is sinus. Okay. طيب. And any abnormality in the heart rhythm is critical. يعني if you find a patient with يعني irregular rhythm, okay, you have to يعني have further investigation for him, refer him to cardiologist, because he would have arrhythmias. We call it arrhythmias. When there is abnormal rhythm, we call it arrhythmia. And we will have another session, inshallah, talking about different arrhythmias, bradyarrhythmias and tachyarrhythmias, wide complex arrhythmia and narrow complex arrhythmia, wide topic. Okay, so to understand the entrance of this topic, you have to know what's normal sinus rhythm. Okay, is it clear? I hope.
Yes.
So now we have how to know that this rhythm is regular. Actually, this is a crash course. I'm giving you the fastest way, the easiest way to know the rhythm and to know the rate and to know other things. Okay, so we have here a very simple way to know if this rhythm is regular or not. Bring a paper, تمام, جيب ورقة فاضي, blank paper, and put a line on an R wave, okay, and put another line on another R wave. Okay, so we have now two lines on this white paper. تمام. Then take this paper and put it on every R wave, and notice if it's always fall in the same place or not. In regular rhythm, it will fall always in the same place. Is it clear how to analyze the rhythm?
Yeah.
Yes.
Tamam. This is the easy way. Usually in the hospital, when we have the ECG paper, take a small paper note from your note and put two lines on it, and مشيها على ال ECG وشوف هل هو regular or irregular. بيبقى معك بسهولة, and don't depend on your eye only, because sometimes they will mislead, find arrhythmias or irregularity in the rhythm. طيب, now for the heart rate. طيب, heart rate, we have two rates, the ventricular rate and we have the atrial rate. Ventricular rate is represented by the QRS, as we mentioned, and atrial rate is represented by the B waves, as we mentioned. طيب, usually we know that the heart rate is one thing why we are separating here to ventricular rate and atrial rate, because in some diseases, for example in heart blocks, the ventricular rate will be different than atrial rate. Okay, and for example in ventricular arrhythmias, the ventricular rate might differ from the atrial rate. Tamam? So in pathological state they are not one, but in normal condition ventricular rate is equal to atrial rate. تمام؟ عدد ال QRS complex هيكون مساوي لعدد ال B waves in normal condition, but in abnormal condition they might be different. There might be many B waves and only few QRS sometimes in pathological conditions. طيب, how to say that this is how to calculate the rhythm, how to calculate the rate, sorry. After determining the rhythm is regular or not, we will calculate the rate. If it's having regular rhythm, it's easy to calculate the heart rate. Look at this very easy way. Look, this is an example. Divide 300 by the number of large boxes between the R interval, between two RR interval, two RR waves. Okay, here we have an R wave and here we have a successive R wave, next R wave. How many large, not small, how many large square in between? Only one large square, as you can see here. So 300 divided by 1 is 300. So the heart rate here is 300. It's just an example because it's impossible to have a 300 heart rate. Okay, here, how much is the heart rate? 300 divided by the number of large squares. 300 by 2 is 150. And here, how much? 300 divided by 3 is 100. Okay? This is the rule. 300 divided by the RR interval in large squares. Is it clear?
Yes, so 300 is constant.
نعم.
يعني 300 ثابتة، يعني دائما
300.
بنقيس فيها.
كيف 300 دائما ايش؟
ثابتة، يعني
ايوه ثابتة.
عشان احسب ريت
نعم
لازم
ثابتة، بس
أحسب
لازم ايش؟ الثابتة برضه لارج سكوير، ما تحسب السمول سكوير. اذا اخذتي سمول سكوير بتخليها 1500، لكن القسمة ب 1500 اصعب من القسمة ب 300. 300 is easier than 1500. Okay, so 300 you can fix it يعني memorize it like this: 300 by the number of large squares, always in regular rhythm, but in irregular rhythm you cannot apply this. Okay, only irregular rhythm 300 divided by the number of large squares. I think it's very easy and very clear. يعني this is a simple way, but the consultant use it. It's يعني simple and effective. طيب. Now let's go for irregular rhythm. If we found that in the first step the rhythm is irregular, how to calculate the heart rate? We just mentioned that 30 large squares equal how many seconds?
6 seconds.
How much? How many?
6 large square. Oh, sorry.
6 seconds. Yes, 6 seconds. So we will count the number of QRS complexes in 30 large squares, which represent how many seconds? 6 seconds. Let's look here. We will count how many large squares? 30 large squares. This is our small squares. And if we count from here to here, there will be 30 large squares. And this represents 6 seconds. As you can see here, this is 3 seconds and this is another 3 seconds. So the total is 6 seconds. Then I know that this strip is 6 seconds. I will count how many QRS complexes are here. We have here 7 QRS complexes. Okay, 7 QRS complexes in 6 seconds, and 1 minute is 60 seconds. So to get 60 seconds, I will multiply by 10. 6 seconds multiplied by 10, it will give me 60 seconds, and 7 multiplied by 10, it's 70. So I know that this heart rate is 70 beats per minute. I hope it's clear.
Yes, clear.
Clear for everyone?
Yes, clear.
I hope. As you can see here, the calibration, as we mentioned in the beginning, should be calibrated. This rule should be when the machine is calibrated to 95 millimeter per second. Otherwise, these equations will not work, and all our values will not work, because we are working, or we are saying our talk about the machine that's calibrated to this speed. Okay. طيب. Now we are done with measuring the rhythm, to determining the rhythm and measuring the heart rate. This is very, very essential. Very essential. Please, if you didn't understand, say before we go any further. Very essential. Anyone, if you didn't understand or didn't get, don't be shy. It's very essential. Yes? Anyone? Inshallah, it will be clear. I hope. Man.
Doctor,
yes.
Dr. Ibrahim.
Yes.
In case, for example, the RR interval aren't showing full squares, should we rely on small squares, for example, and multiply?
It's going to be, you mean at the end? You mean at the end of the ECG strip?
Maybe, for example, the QRS complex is not in line with the border of the large square. It's like in the middle of the large square.
Yes, count it.
So,
count it.
Okay.
Count it. If it's in the line, count it. Away from the line or before the line, don't count it.
Okay.
Okay. Anyhow, this an essential skill, but now the ECG machine count the heart rate. Okay, يعني in clinical practice, you will find that the ECG paper contain the heart rate. The machine will automatically calculate it. But an essential skill for you to calculate the heart rate, because in exam you might be asking to tell the heart rate. Okay.
Hey, doctor.
يعني this is an approximation, not 100% accurate. Approximation for the calculating the heart rate, for calculating the heart rate. Okay, what's the normal heart rate? Yes.
60 to 90.
60 to what?
100 is normal.
Yes, from 60 to 100 is normal. Is that always?
No.
Okay, where we have different normal values?
Maybe it's above of 100 or below 100.
We said that normal heart rate is from 60 to 100, but in athletic people, you are right, Ali. In athletic people, they have less. Okay, their resting heart rate will be 60. And also in pediatric population, we have different heart rate. So for example, dealing with a newborn, just yani born now, okay, the average heart rate for him is 125, and the upper limit is 190. Imagine, okay, and the lower limit is 70. So they will have more more beating heart than the adults, because their heart is smaller. So how they will compensate? They will pump more. Okay, their heart is small, so they will pump more to compensate for this small heart. Their heart is very small. So in pediatric, we have different values. This I put it just for information for you to know it. No need to memorize these numbers. Only to know the average for the newborn is 125. Okay, now determining the axis. I hope that you are still awake with me. You didn't sleep yet. I hope. But inshallah, we are approaching the end of our presentation. The axis is important. It represents the mean direction of the ventricular depolarization. As we mentioned, that all the heart is depolarizing. This myocardium is depolarizing. This myocardium is depolarizing. And the collection of all of these depolarization, we have one main vector. المايوكارديوم اللي هنا جالس يصير فيها ديبولايزيشن، واللي هنا جالس يصير فيها ديبولايزيشن، فمجموعهم كلهم بمختلف الاتجاهات هيعطينا محصله واحده اللي هي ماشيه بالاتجاه هذا. تمام. فبالنورمال هارت لازم يكون الاكسس in this position. Okay, and here there is a way saying sentence saying in the frontal plane. Anyone could explain to me what does that mean? Okay, as we said that we have chest lead and limb leads. Chest lead will look to the heart in the horizontal plane. As you can see, it's like a circle going from here to here. This is the horizontal plane, and the frontal plane is determined by the limb leads. Okay, this is the frontal plane by the limb leads. So the axis, we are considering it in the frontal plane. We don't need the axis in the horizontal plane. Okay, is it clear?
Yes.
Can you repeat it?
Okay, I said that when we are looking to the axis of the heart, we are looking it in the frontal plane, not in the horizontal plane. As I said, we have all the leads are represent cameras. So we have these cameras here looking in this horizontal, they are going like this, looking like this to the heart, looking like this horizontally. يعني من صدرك من برا إلى جوا، جالسين يطلعوا من الداخل إلى الخارج. تخيل صدرك، حط يدك على صدرك وادخل فيها لجوا. فهذول هم الهوريزونتال اللي هم ايش؟ اللي هم التشست ليد. بينما الليمب ليدز بيطلعوا من فوق لتحت او من اليمين لليسار. تمام. بالهوريزونتال بالفرونتال بلين. I hope that's clear. if it's not clear, this point is very important, so I might elaborate it يعني using the camera. Am I visible to you? Or the camera is not working? Am I visible?
Not yet.
Yes, you are visible.
You're muted.
Doctor, your mic.
I'm sorry. Right. Imagine that we are looking, this is the heart, okay? Imagine this is the heart, and we have the chest lead. Chest lead are looking like this, in the horizontal plane, okay? Whereas the limb leads are looking from this plane, the frontal plane. They're looking superior, they're looking inferior, they are looking from the lateral side, okay? What we have in the lateral side, which leads? For example, let's the lateral side, let's say. Which lead here we have in the lateral side?
5 and 6. V5 and V6.
Yes, V5, V6, and also
AVL.
AVL and lead 1. These are from the lateral side, okay? And from the inferior side, which leads?
Lead 2, 3, AVL.
Lead 2, lead 3, lead AVF, okay? So this is the front, the limb leads. Limb leads are looking from this plane, and the chest lead are looking like this from the horizontal plane, okay? So for example, if this is V1 and V2, this V3, V4, V5, V6, okay? And when we have, for example, as I said, we have the V7, V8, they will go from the back, okay? So I hope that become now clear.
Yes, yes.
Okay. Now we will come back. We will come back to the axis. What is the normal axis? As I mentioned, someone asked me about why it's mentioned in negative, because in textbook they will say that the normal cardiac axis lie between the -30 till the +90, and in this circle, as you can see here, from -30 till +90 is normal axis of the heart. Okay. How to determine the axis? If it lies in the -30 degree till the -90 degree, it's left axis deviation. If it lies between the 90 degree and 180 degree, it's right axis deviation. And when it lies in the between the -90 until 180, it's an extreme right axis deviation. What does that mean? What does that mean, axis deviation? Axis deviation, it's like saying, for example, if a patient come to you and say, I have an abdominal pain, okay? Is it a disease, abdominal pain? Abdominal pain is not a disease, okay? It's a sign or symptom the patient is having, okay? When we look for the ECG and we found a deviated axis, we have to investigate more. We have to know why this patient developed deviated axis. It like have a differential diagnosis. For example, if you diagnose a patient with left axis deviation, we have this differential diagnosis. So left axis deviation, it's not a disease by itself here, not a disease by itself, but it's an abnormal ECG finding. For example, here left axis deviation has these common causes, and right axis deviation has these common causes. So as a first year student level, and you are not required to know the causes, okay? For second year student and older, you have to know some of the causes of the left or right axis deviation, okay? طيب. Now these numbers you have to memorize. You have to memorize that the normal is from -30 till +90, and the right axis from +90 till +180, and the extreme axis is from +180 and -90. Is it clear? You have the numbers here. Is it clear?
Yes.
Yes, that's great. You can see here that we can determine the axis on the you know that in ECG paper we don't have this degrees. So how would you determine the axis? We don't have degrees in the ECG paper. Anyone know?
By lead 1 and EVF.
Yes, great, Hassan. By looking to the lead 1 and lead 2, we look to the QRS complexes in these lead 1 and lead 2. Okay, look with me here. This is the normal. Okay, normal axis of the heart from +90 till -30. Okay, this circle is a little bit inaccurate, but it gives us the idea. From here, it's normal. Okay, so we will look to the QRS complex. If it's both are positive in direction, so it is a normal axis of the heart. Okay, normal axis, both QRS complexes are positive in lead 1 and lead AVF or lead 2. You can use anyone you want. Lead 1 plus AVF or lead 1 plus lead 2. Both are the same. Okay, when both QRS complexes are positive in these two leads, it's normal. Okay, when we have a positive in lead 1, look here, we have positive in lead 1 and negative in lead 2 or lead AVF, it's a left axis deviation. And some put a mnemonic or use a mnemonic that these are going far from each other. يعني كل واحد رايح بعيد عن الثاني. تمام؟ فهم يعني زي ما تقول left axis، يعني في بينهم شيء كأنهم متزاعلين مثلا. تمام؟ كل واحد رايح بجهة، فهذا left axis deviation. بينما طلع على look at the right axis deviation they are like shaking hands، يعني كأنهم تصالحوا. فاللي فوق الليد 1 هو نيجاتيف وليد AVF او ليد 2 بوزيتيف، فكانهم جالسين يسلموا على بعض. فلما نشوفهم جالسين يسلموا على بعض عرفت انه right condition، يعني right axis deviation. تمام. when both are negative this extreme axis deviation. I hope that's clear.
Yes.
Okay, this simple way how we can يعني know the axis of the heart. طيب memorize this because it will يعني make things easier. As we mentioned, we have differential. I just put it here to your knowledge. No need to memorize now for first student especially. Okay, let's practice. Could someone tell me the rhythm?
$200.
I said the rhythm.
Oh, okay.
Yes,
regular.
normal, regular rhythm.
Regular.
Yes, regular rhythm. Okay. So we have regular sinus rhythm. We said that we have to draw a line on a blank paper and put it, and we look that RR interval are regular and constant. Okay, and also our B wave is present in lead 1 and lead 2, and AVL it's present and it's positive, so it's sinus. And every QRS is preceded by B wave, so this is sinus rhythm. But I made a mistake. Could someone tell me what I made?
There is no complete lead.
Actually, it's not 100% mistake, but according to what I said in the beginning, it's a mistake. As we mentioned that rhythm should be analyzed on the long strip. Okay, but usually, or sometimes you don't have the long strip, so analyze it in this. It will give you some idea. Okay, when you don't have the long strip, here there is no long strip, so analyze it here. So regular sinus rhythm. Okay, the rate
267.
You are right. Where is it written?
Up to the paper.
Yes, yes, you got
150.
yes, mashallah. يعني I was يعني how you get it 67 by this accuracy. So it was written, as I mentioned to you, that new يعني now ECG paper came with the يعني calculated heart rate. So without depending on this, for sure in the exam doctor will remove it. So يعني let us apply our method. How many large squares?
2 or approximately maybe 2 or 3.
According to her and half.
Between 2 R, I think it's 2, just 2.
In this step, we have 14.
Look here. This I think is good to analyze. Here we have 1 large square, 2 large square, 3, 4, 4, and a little bit. So we will have 300 by 4. It's going to be 75, and this is more than 4. So it will be lower than 75. It's 67. If you write in the example 70, it would be good because one large square, 2 large, 3, 4, and 4.5. Okay, so 300 by 4.5, it's going to be around 70. Is it clear?
Yes.
No, again, please.
طيب, to calculate the heart rate, okay, this is firstly regular or irregular?
Regular.
Okay, so we can use the 300 method, right?
Yes.
Okay, so 300 method say calculate how many large squares between 2 successive R waves. We can use any R wave, any 2 R waves in the ECG, but I use these 2 R waves. Why I use these 2 R waves? Because they are lying on the line, so it's easy for me to count how many large squares after them. So look, that this is lying at the line, so it's easy to calculate how many squares. This is يعني a little bit difficult يعني because it's not in the beginning of the square, but also you can use it. For example, look here, 1, 2, 3, 4, and you have here a little bit يعني 4.5, the same. So 300 by 4.5, it's going to be giving you around 70. Is it clear?
Yes.
Okay.
I have a question.
تفضل.
Can we use the 6 multiply 10 method in the regular sinusoidal?
Of course you can use it.
Oh,
But
okay,
you cannot use the 300 method in irregular. Oh, sorry. Could someone tell us the access? Even if you cheated, no problem. What's the access here?
Left axis.
Yes, left axis PR, because they are like going away from each other, not normal axis. Normal axis should be both positive QRS. We can see positive QRS and negative QRS in the second lead. And also, if you look at AVF, you can see it second, negative also. So going back to our rule here, you see when they are one is positive and other is negative, this is left axis deviation. Okay. طيب. Now, what is next? Could someone predict what's next?
Maybe do echo.
No, I'm not talking about the condition of this patient. I'm talking about the ECG. What we will explain next after the access.
Maybe where is the problem?
We will explain the B wave after this. The third step. The first one is the rhythm, then rate, then the access, then the fourth one is the B wave. Okay. Okay. تمام. طيب. I think there are here some third year, fourth year, fifth year student with us. Could someone find an abnormality in this ECG?
There is ST elevations.
Where are these ST elevations?
I think there's P mitrally.
There is no B mitral or B pulmonary. We'll explain that later. But the one who said there is ST elevation and hyperacute T wave.
The anterior septal.
Now.
The anterior septal.
Yes, there is ST elevation here, as you can see here in V1, V2. And also, what about the QRS complex? Anyone notice it's broad, not narrow? Broad QRS complex, wide. We didn't explain that yet, but it was like يعني تحفيز بس اللي معنا الشباب. طيب, we will explain them later. Okay. طيب. Now we will talk about the B wave. Computer.
يلا شباب يا شباب كيفين شلونك صح؟ عاملين؟ أمور؟ الله يسعدك.
عزي على تطفي المايك عندك؟
بس
ما مشكلة. طيب طيب now for the B wave it should be present in all lead. And what about its duration? Now we come to something is not fine يعني or not funny. It's memorizing the values of the waves and interval. You have to memorize the values, but inshallah I will make them easy for you. The B wave duration, what do we mean by duration? By its يعني the axis here. It should be from 60 to 100 millisecond. Okay, not exceeding 100 millisecond. And 100 millisecond equal how many small squares? 2.5. Because as we mentioned, each one small square equals how many milliseconds?
40.
Yes, 40. 40, yes. Yes. So 100 millisecond will be how many small squares?
How many?
Yes, 2.5 small squares. So the duration يعني لما تطلع على البي ويف لازم ما تكون أكثر. Look at this normal B wave. It should be not more than 2.5 small squares. Here we have 1 and a little small square. So it's normal duration. Look at this B wave. It's prolonged. It's approximately 3 small squares. Okay, it's 2.5. طيب. And what about the amplitude? Also 2.5 small square. So memorize it like this. B wave 2.5 ب 2.5. Okay. B wave 2.5 small square in duration and 2.5 small square in amplitude. تمام. Here we have high amplitude. It's above 2.5 small squares and reaching almost 3 small squares. Anyone now could now we are not talking about pathologies. This session is only considered for the normal ECG, but I might sometime ask about pathology, like just to يعني motivate you. What is this? Anyone know this?
Left atrium hypertrophy.
Okay, so you are right. What's called bimitral. And this is B pulmonal. This is presenting M shape, so it's easy to remember it's bimitral, and this B pulmonal. Okay, this B wave. How to analyze it? تمام. طيب. It should be positive, as we said, indeed 1 to AVF in the sinus system, and negative in AVR. طيب. Now talking about the BR interval. BR interval also mainly assists in lead 2. And you have to know the duration of PR interval by the heart. By the heart, you have to know the duration of PR interval. It's from 120 to 200 milliseconds. So from 3 small squares up to 5 small squares, or less than 1 big square. يعني, as we said, the B interval is from the beginning of B wave to the beginning of Q. So this is the B interval. Okay, should not exceed 1 big square or 5 small squares. Okay. Anyone could say to us or link that to a disease, the BR interval? Anyone?
AV block.
Yes, AV block. Yes, AV blocks are related to the BR interval. So you have to know by the heart how much is the BR interval. يعني for practical point of view, and as we are in crash course, don't memorize the numbers. Okay, for يعني interpreting the ECG, memorize the number of small boxes. It's easier. Here for BR interval from 3 to 5 small square, and in B wave it was 2.5 by 2.5. So it's easy for you to memorize the number of small squares or large squares. Okay. So the amplitude يعني الارتفاع تبع البي ار انترفال we have the B wave. B wave تكلمنا قبل عن الامبليتيود تبعها، بس في عندنا البي ار سيجمنت. البي ار سيجمنت لازم يكون ايزوالكتريك. تمام، هذا هو البي ار سيجمنت من هنا لين هنا. هذا البي ار سيجمنت تكلمنا عنه قبل شوي، لازم يكون ايزوالكتريك. تمام، واضح الامبليتيود تبع البي ار انترفال.
Yes.
طيب لازم تكون preceding each QRS complex and should be constant also. Could someone interpret this to me or to us? طيب, let's take it step by step. What is the B wave? This one or this one? This, صح? This is the B wave. This QRS. تمام? This B wave, this QRS, this B wave, this QRS. Let us notice the BR interval. Is it normal?
No.
Prolonged.
Yes, prolonged. Why? Is it contained in this large square or it's exceeding it? It's, as you can see, as you can see that it's exceeding the large square. It's the large square and up to here. And in the next one, you can see here, from here to here, it's increasing. As you can see, from here to here, it's increasing. So this is abnormal BR interval. صح?
Yes.
Yes. And the B wave is normal. B wave is normal, but the BR interval at all يعني is not normal. It's prolonged. Could someone tell us the diagnosis here?
Second degree heart block type 1.
Yes, great. ما شاء الله ممتاز. Second degree and type 1. MOPS type 1. Then now we are going to talk about the QRS complex. As we mentioned that QRS complex is composed of 3 waves, Q, R, and S. طيب, QRS complex, the duration is very, very important. The duration is very, very important. And I want you to focus with me here in the duration of the QRS complex. QRS complex should be from 60 to 100 milliseconds. Okay? And usually they say it's less than 3 small squares. تمام? But we just said that 100 millisquare equal to how many small millisecond equal how many small squares?
We said 2.5.
2.5. تمام? So to be accurate 100%, the QRS complex should be less than 2.5 small squares. But sometimes to make it simple, they say less than 3 small squares. تمام? Is this point clear?
Okay.
Yes. يعني normal from 60 to 100. But يعني sometimes they say from 60 to 120. Is it clear? It's very, very important to know the duration of QRS complex. Memorize it by heart. طيب. As I said, I will make it easy for you. You notice that the duration here is half of the age of the BR interval, the half. The QRS complex duration is half of BR interval. This from 120 to 200, and this 60 to 100. يعني الضعف BR interval ضعف ال QRS. تمام؟ واضح؟ ال QRS هي الدوريشن تبعها نص البي ار انترفال. البي ار انترفال شفناها كيف هي، كانت 120 الى 200. وبرضه البي ويف هي زي الكيو ار اس نفس الدوريشن. البي ويف من 60 to 100. So B wave and the QRS the same duration, so it's easy to memorize. Less than 2.5 small square is the duration of normal B wave and the duration of the QRS. less than 2.5 small square or from 60 to 100 millisecond. And the duration of BR is the double. تمام. I hope that's clear. Clear? And look here, the duration of B is similar to duration of QRS, the same. Atrial depolarization take the same time of ventricular depolarization from 60 millisecond to 100 millisecond, and QRS also from 60 millisecond to 100 millisecond, and the BR interval from 120 to 200. This is the normal. Any value in between is normal. Yani any value between 60 to 100 is normal. Yani 70, for example, 80 for QRS is normal. Okay. When we have يعني duration, this is called narrow. When duration is between 60 and 100, it's called narrow QRS. طيب, could someone give me an example when we have wide QRS? Anyone? Could give us an example. Ventricular tachycardia, great. Also, bundle branch blocks. When you have bundle branch blocks, طيب. From 100 to 120, they call it incomplete bundle branch block, and above 120, it's called complete bundle branch block as a disease. تمام. I hope يعني it's clear for you. تمام. Now talking about the amplitude. The amplitude of the QRS you don't have to memorize because it varies from lead to lead. So this is easy. Don't memorize the amplitude of QRS, but memorize the amplitude of B wave. Okay. And BR interval we said that BR segment is isoelectric. يعني هذا البي ويف لازم نحفظ الارتفاع تبعها ولازم نحفظ الدوريشن. الكيو ار اس ما لازم نحفظ الارتفاع الامبليتيود بس نحفظ الدوريشن. البي ار انترفال او البي ار سيجمنت هي ايزوالكتريك. فواضح يعني بس نحفظ انه البي ويف 2.5 ب 2.5. نحفظ انه البي ار انترفال هي لازم ما تكون اكبر من 1 بيج سكوير، والكيو ار اس كومبلكس ما لازم يكون اكبر من 3 سمول سكوير. بس هذا كله لازم نحفظ، ونحفظ عدد السكويرز. البي ويف 2.5 ب 2.5. البي ار انترفال لازم ما تكون اكبر من 1 لارج سكوير. الكيو ار اس كومبلكس لازم ما تكون اكثر من 3 small squares. I hope that's clear. طيب. We have something called R wave progression. يعني the R wave, this R wave should progress from V1 to V5. Lead V1 to lead V5, the R wave have to progress. يعني as you can see here, V1, the R wave is smooth. Till V5, R wave should be progress. Okay, when we find that R wave is not progressing, this is pathological. We have to find the cause, like as we mentioned, the cardiac axis deviation. We have to look for the cause. Here also, when we have poor, it's called poor R wave progression, we have to look for the cause, and it's up to V5 only, because after V5 it starts to decrease again. As you can see, V6 is decreasing. Also, the S wave is the opposite. S wave is going to be decreased. Okay, for V1, S wave is deep, but whereas in the V6 there is almost no S wave. Here there is S wave. Okay, let us practice on the naming the QRS. Could someone name this QRS for me? Anyone? This is R capital. Okay, and this is S small. Okay, R capital and small. This is QR, sorry, Q small and R capital. I hope it's clear.
Question.
Yes.
Should we know it in the first year?
Which one?
Like this, when the R is positive and the Q is negative before the R and the S is negative.
Of course.
After
of course.
the R.
Of course, this is basic yani, of ECG, and
Okay.
I think it's easy. Yani,
yes,
we said that the first negative is Q and any positive is R, and negative after R is S. Just this. It's easy and not difficult, And when we have large wave, we put capital. And when we have small wave, we write the letter with small. And when we have 2R, the next one will be, the second one will be written as R dash. It just needs a little memorization, not difficult.
excuse me, Doctor.
Yes, تفضل محمود.
بس مداخل بسيطة. I think first year you finished 1.2.
Yeah, I think they have the final exam next week.
Because as I memorized the first time we take or we study the ECG in the second year, not the first year.
No, they talk the ECG. They can't confirm that to us. Did you take the ECG or not? If you have first year student here listening to us, as I remember, we took it in the first year. Can someone confirm? In the chat, maybe. Maybe there is no one first year student here. No problem. طيب.
Yes, we take ECG.
Okay, that's great. تمام. طيب, now we are going to talk about the Q wave. تمام. Q wave, I want you to memorize, just to memorize that Q wave is not always normal. يعني في بعض الليد بالاي سي جي we should not see Q wave. تمام. When we see Q wave in those lead, we call it pathological Q waves. They could indicate MI, like ST segment elevation, so they are serious. Okay, new Q wave appearing in a patient with chest pain is like an indication for, it's like representing an MI, so it's serious. So I want you just to know where we can see it normally. Normal, it's to be seen in lead 1, 3, AVL, V5, V6. Yani to make it easier, to be seen in the lateral leads, as you mentioned, 1, AVL, V5, V6 are the lateral leads. So it's normal to be seen here in addition to lead 3. And also not only that, the duration of the Q wave itself, not the whole QRS complex, no, the Q wave itself, the duration should be less than 1 small square, and the amplitude should be less than 2 small square. In this condition, we call it normal Q wave. Otherwise, if it's deeper or wider or in an abnormal lead, so it's called pathological Q wave, and it has a differential also. I hope that's clear. Go and memorize this. Okay, memorize this. I hope that's clear. You might didn't take this in your study, I guess, because in the first year I didn't study the R wave progression and I didn't study the Q wave progression. But actually, I'm explaining you not for the sake of the college exams. I'm explaining to you for the sake of your knowledge as a medical student. Okay, so inshallah, I want you to don't have gaps. So for that, I am explaining this statement for you. So don't be bothered. Just bear with me. And we finished almost everything. We are just now with the ST segment. I want you to know that the ST segment is isoelectric, but sometimes it might be elevated or depressed by less than 1 small square, and is accepted. We don't say in this condition ST elevation, or we don't say significant ST elevation or significant ST elevation. Okay, but when sometimes you might have depression in the ST wave, and the shape of ST depression has many names, and we don't want here to put the names. Just know that here there is for example a concave depression, for example here. There are other forms of depression. Also, you might have an elevation in the ST segment. Okay, look here. When we say that we have significant ST segment, if it's elevated by more than 1 small square, we said that this 1 small square is accepted, but elevation above that 1 small square in limb leads, or more than 2 squares in pericardial leads or chest leads, is significant elevation and requiring attention. Okay, is that clear? Limb leads more than 1 small square, and pericardial leads more than 2 small squares. Is that clear? I hope it's clear for you. Okay, you have to memorize these numbers. Now for the T wave, the amplitude is less than 10 millimeters, who could tell me how many squares is 10 millimeter? $10 millimeter amplitude. How many small square or large square? Anyone could tell me?
2.5.
No.
Maybe 2. No.
No. As
Too
we said
small?
in the beginning. Yes.
2 small squares?
2 large squares. Because as we said in the beginning, 2 large square. As we said in the beginning, 1 millimeter equal 1 small square. Tamam? So 10 millimeter equal 10 small squares. 10 small squares are 2 large squares. 2 large squares. Clear? Is it clear? I think we this
Again,
one.
please.
طيب. No problem. As I said here in the calibration slide, that each one small square is equaling 1 millimeter. 1 small square equaling 1 millimeter. So when we say 10 millimeter, we are saying 10 small squares. 10 small squares equal how many large square? 2 large squares. Tamam? Because 1 large square contain 5 small squares. So 10 small squares will be 2 large squares. Tamam? Tamam?
Okay.
As we mentioned here, the amplitude should be less than 2 large squares, and forget about this. Just know that it's less than the R interval, R wave. يعني ال T wave لازم ما تكون أعلى من ال R wave أو ما تزيد عن ثلثين ال R wave. Should not exceed 2/3 of R wave. Okay? The polarity يعني the T wave is usually similar to QRS. يعني QRS here is positive, and T wave usually followed. When QRS is positive, T wave is positive also. As you can see here, we might have peak T wave and we might have hyperacute T wave. Or here, for example, it's an example of ischemia. Here it's an example of hyperkalemia. I'm just here giving an example of the abnormality to know what is normal. This is the normal. Compare it with this. It's approximately the same height of R wave, so it's abnormal. It's hyperacute. Sometimes you might have inverted T wave. Inverted, going from here to here. Okay, so each one of these indicate a disease. Here I want just from you to know the normal, so when you have the disease you can know that there is a disease. Okay. Just one point to add, as I said here, this QRS complex, is it positive or negative? You can see here we have negative waves and we have here positive wave. So how to say this is positive or negative QRS?
Assessing maybe state of S wave.
Now,
if the S wave is negative, then the R will be positive.
No, actually we have, we look at it generally. We look where is the maximum wave. Here the maximum wave is the R, so it's maximally positive. But sometimes we might have small R wave and large S, so it's a negative QRS complex. Is it clear?
Yes.
Like here, for example, as we mentioned, the nomenclature. Where was this one? Here, for example, as you can see, this one is a negative QRS complex because majority of it is negative. Tamam?
Nice. Yes.
Here also, negative QRS complex. Majority of the waves are in the negative side. Here also, negative QRS complex. Here, clear that it's positive QRS. Positive QRS. تمام؟
تمام.
طيب. Last, before the last, we have what? That the last thing, alhamdulillah. We have what's called the QT interval. Anyone could tell me from where does the QT interval start and end? Anyone?
From the beginning of the T wave.
From the beginning of what?
QRS complex.
Yes.
To the end of T wave.
Great. ممتاز عبد الله صح؟
نعم.
ممتاز. Q wave from the QT interval, as you mentioned, interval. Why it's interval, not segment?
Has wave.
Yes, great. So QT interval, it's important also to be looked and analyzed, and it's usually from 0.34 till a second till 0.44 second. And if we say by the millisecond, it should be from what? From by 10 milliseconds.
340 maybe.
Yes, ممتاز. It should be from if you put them here from 340 because we were using the millisecond from the beginning. So let us complete by the millisecond. Okay. Millisecond. Or as a general rule, QT interval should not exceed half of RR interval. تمام يعني as a general rule but not accurate that where is this one? Okay. The QT interval should not exceed the half of RR interval. يعني لازم ال QT interval ما تكون أكثر من نص ال RR interval. For example يعني إذا قلنا ال RR interval 10 ال QT لازم ما تزيد عن 5 كمدة كدوريشن. تمام؟ clear؟ طيب. Anyone could tell me a condition that could be precipitated by prolonged QT and QET interval? A fatal condition.
Drug toxicity. Torsades de points.
Torsades de points. Just know the name now, and further session, inshallah, will explain to you. Torsades de points could be precipitated by QT interval. طيب, what might cause a prolonged QT interval?
Drug toxicity like antidepressants and antipsychotics.
Great, quinidine also. So QT interval could be elongated by some drugs. So last thing to say in this presentation that as I said that half of RR interval is not accurate. The accurate is to know the numbers. Okay, depending on the heart rate. For example, when we have a heart rate of 70, the RR interval should be 68. Okay. 86, and the upper limit of QT interval should be 40. So it's like a fixed values, okay? You have to know. But as an approximation, if you didn't, and I don't ask you to memorize these numbers, no one of us memorized it, even in the 5th year. So just know that you have a reference number to go to them to compare. Is this the QT interval is normal or not? Okay, and for the sake of completeness only, I want to say that we have something called corrected QT wave. What's corrected QT wave? It's corrected to the heart rate, as we mentioned that each heart rate has different QT wave. So what we do, we corrected QT wave, we put small c indicating that is the corrected QT. It's the measured QT, يعني ال QT اللي انت قستها بنفسك شفت كم small square كم large square divided by the الجذر التربيعي تبع ال RR interval. نسيت ايش الجذر التربيع anyone could remind us? Anyhow, this is for saying to know the equation for calculating the corrected QT interval. By that, we reach the end of our presentation. I hope, inshallah, you found now ECG easier, more simpler, and you are ready to go through the next session with the consolidate understanding of the ECG. Anyone have a question?
Thank you very much, Dr. Ibrahim. One question about the U wave. Should we be concerned about it right now or later?
UF it might be appearing sometimes in normal condition. يعني UF it's not يعني sometimes unknown origin, and it's sometimes associated with some diseases. So at this level, يعني no need to go through UF.
Nice. Okay. Thank you very much.
Welcome. Anyone has another question?
Could we have the slides?
Of course, inshallah. Could you please raise the hand so let us know how many are still with us? I'm not doing that for taking attendance or something, but I'm an organizer for the course. I'm actually interested in knowing يعني, how many people are يعني, following. Actually, that's great. When we see many raised hands, we are like motivated to do more. Thank you all for your attendance, and inshallah slides will be uploaded later, and you will be provided with the link for them. I hope this also session was recorded. If it was, inshallah, we might the organizers might upload them to you. Thank you. Any question?
Okay, thank you, Ibrahim. Inshallah, it was very nice presentation, as I got from my colleagues' feedback, because I actually attended in the last few minutes.
Thank you.
I just want to say the evaluation link has been sent in the chat. Please, before leaving the session, make sure to evaluate the presenter, because we will take the attendance from the evaluation link. Thank you.
Please go through this thing. It's in the chat. Thank you, Basant, for organizing this course.
You are welcome.
Excuse me.
Yes.
I think there is a problem with the link.
There is a problem. What is the problem?
Yes, the link is not
You
working.
have to open the link from your college email, university email.
Okay. I think there is no questions. Thank you for your attendance. Assalamu alaikum.
Thank you.
Welcome.